I'm Dr. Eric Forman, the Medical and Laboratory Director of Columbia University Fertility Center, and I'll be providing an update on randomized controlled trials using PGT-A. It is well known that the incidence of aneuploidy, the presence of an abnormal number of chromosomes in the oocyte, increases significantly with increasing maternal age. To combat the declining success rates of in vitro fertilization with increasing maternal age, various selection tools have been studied. The most used and studied technique has been embryo biopsy for preimplantation genetic testing for aneuploidy, or PGT-A. The concept behind PGT-A is that preferentially transferring chromosomally normal, or euploid, embryos would result in improved outcomes, namely higher implantation rates and lower miscarriage rates. The initial version of PGT-A utilized a technology called FISH, or fluorescence in situ hybridization. While promising in early studies and useful in other medical settings, this technology was not fully validated for clinical IVF. A series of randomized trials found this technology was not helpful and may have even been detrimental. Proponents of PGT later argued that the failure of FISH lay not in the concept of genetic testing, but rather the technology itself, which was only able to assess a limited number of chromosomes and may have had a high false positive rate. In addition, the single-cell day 3 biopsy may have had a negative effect on the embryo's implantation potential. Later versions of PGT-A have used more robust and validated comprehensive chromosome screening technologies, combined with a later stage biopsy of the trophectoderm layer of a blastocyst. One trial found improved safety of trophectoderm biopsy as compared to cleavage stage blastomere biopsy. The technologies studied to date have included array comparative genomic hybridization, or CGH, real-time polymerase chain reaction, or PCR, and next-generation sequencing, or NGS. Given the misleading experience from retrospective FISH trials, it is important to analyze data from prospective randomized trials when assessing new technologies like PGT-A. A recent meta-analysis of the published literature on PGT-A identified 3 randomized trials to review. The first trial, by Yang et al., evaluated CGH-based PGT-A in young, good prognosis patients. In the study group, blastocysts were biopsied on day 5, and a single euploid blastocyst was transferred on day 6. There was a significantly higher ongoing pregnancy rate, 69% versus 42%, without PGT-A-based selection. The mean age of these patients was 31, and they had 8 blastocysts on average. A second trial by Scott et al. Used rapid real-time PCR. The study group had blastocysts biopsied on day 5 and up to 2 euploid embryos transferred the morning of day 6. The control group had 2 day 5 blastocysts transferred. The study group had a significantly higher live birth rate of 85% versus 68%. The mean age was 32, with an average of 7 blastocysts in each group. Using the implantation rates, it can be calculated that the twin rate from this trial was 60% in the PGT-A group. Given the high implantation and twin rates demonstrated in the Scott trial, a trial by Forman et al. Sought to determine if PGT-A could be coupled with elective single embryo transfer to maintain comparable delivery rates as double blastocyst transfer. In this trial, 175 patients were randomized with a mean age of 35 and 5 to 6 high-quality blastocysts on average. The study group had a 61% delivery rate after euploid single embryo transfer, compared with 65% after untested double blastocyst transfer, which fell within the predefined non-inferiority margin. As expected, there was a significantly lower risk of multiple gestation and subsequent obstetrical and neonatal complications in the group that had a single euploid blastocyst transferred. A meta-analysis of these 3 trials demonstrated significantly higher implantation rates with the transfer of euploid embryos and led to the recommendation by the American Society for Reproductive Medicine that single embryo transfer should be performed when transferring euploid embryos, regardless of patient age. A multi-center trial of next-generation sequencing-based PGT-A was recently published. This study of 661 patients was performed in 34 centers using 9 PGT laboratories. This approach failed to demonstrate improved live birth rates per transfer, but in a sub-analysis there was a higher implantation rate amongst the 35 to 40-year-old cohort. One concern is that 17% of embryos were deemed mosaic and ineligible for transfer. Subsequent studies have shown that embryos with a predicted mosaic result using this NGS platform can result in apparently healthy live births. In conclusion, single-center RCTs in good prognosis patients have demonstrated that PGT-A can be used to enhance selection for elective single embryo transfer. It's important to remember these were all single-center trials in mostly normal ovarian responders who produced multiple blastocysts. In addition, these technologies did not assess for or report the presence of potential mosaicism in embryo biopsies. More research is needed in other populations, including diminished ovarian reserve and recurrent implantation failure. More study is also needed to demonstrate the efficacy of next-generation sequencing-based testing platforms with lower reported mosaicism rates or in which mosaic embryos are eligible for potential transfer. Thank you for watching this review of the published randomized controlled trials studying PGT-A after IVF.